Hello, I'm Wally Haas. I'm Executive Director of Transform Rockford and your host for Rockford on the Record. You may notice that our background is a little bit different today. We are recording from the City Stage studio in Rockford. Today, my guest is Jason Holcomb, who is the Region 1 staff liaison for the Winnebago County Mental Health Board. Now, today we want to talk about mental health issues in our community and how things have changed over the last 5 or 6 years. Mental health is a serious topic, one that is not discussed enough unless we have a crisis or unless somebody's asking for money. But we want to concentrate on lives touched, lives changed, and lives saved that during the last few years especially. So to set the stage a little bit, Singer Mental Health Center closed in 2012, and even at the time of its closing, it was not the facility it had once been in its heyday, but it still provided needed services. Now, when Singer closed, the state of Illinois promised that $14 million would go to the city of Rockford for supportive housing within the community. And that never happened. Winnebago County has never had a dedicated funding source for mental health services, unlike other counties. For instance, McHenry County has a 708 board and levies a property tax that generates $14 million a year for mental health services. Most counties in Illinois have that. But Rockford was the largest urban community within the state of Illinois without any dedicated funding for mental health services. That changed in 2020 thanks to voters who 62% of whom approved a 1/2 cent sales tax for mental health services. And so, Jason, with that as the backdrop, what has changed from the time that that money has become available to today?
Yeah, thank you. That's a great question. So a lot has changed. Of course, at the same time that the tax was being approved, I don't know if you remember, March of 2020, I remember going and voting as a resident of Winnebago County and seeing some hand sanitizers bottles on all of the tables, and it was kind of like right at the beginning, right? And so, of course, our community has changed a lot because we just went through a pandemic, and so what that did in the nonprofit sector, what that did in the healthcare sector, and the mental health care sector was very dramatic in and of itself because you had increased need and you had lack of resources, workforce issues. So we were operating all in that environment and really, I think, had a sense of urgency coming out of the gate with that approval to understand not only did the voters want this and show up with a very strong emphasis over 62% approval, but also we know the community need is really high right now and agencies are struggling. So we went to work pretty quickly to develop our first strategic plan, which involved interviewing through survey all of the agencies that were providing direct service and trying to understand what their immediate needs were, what their strengths and their capacities were, and also what the service gaps in our community were, and just went to work to try to fill those gaps. And so that was kind of the first few years there. The board established a set of priorities. As you mentioned, supported housing, that was one of those. Crisis response services, that's another one of those. Case management, more psychiatry, things like that. And then opened up for the agencies to request funds to really fill service gaps in those priority areas. And so where we're sitting now, really finishing up the third year of programming coming up at the end of May. We have over 40 funded programs in total, about $18 to $20 million a year that's going out in awards. And we're seeing a lot of those gaps that we talked about as a community in 2012, right. 2013, 14, you look at all these different advisory groups and research groups, they kept seeing the same thing. We don't have this type of service. We don't really have a good crisis response system. We don't have enough supported housing. We're working towards having those things now. We've got a really great ecosystem of crisis response services with a co-responder team. with better 911 systems that screen mental health calls and really identify what the mental health need is, with mobile health teams where on the paramedic side partnered with UW Health, they can go out and do the follow-up and make sure that people who need more mental health resources are connected with care. We've got that in the crisis space. We have now a fully 24/7 facility in the crisis residential program that Rosecrans operates. That was operated on a fee-for-service model for so long. And in a fee-for-service model, what you end up with is you really have to operate in your high capacity times of day, because on fee-for-service, you've got a productivity standard, right? If you're an 8-hour a day employee, you might have, hey, I got to get 6 billable services per day. Otherwise, companies losing money and those positions can't be supported. So this local funding has allowed for that crisis residential facility to be able to take intakes 24 hours a day, 7 days a week, which is really important as a key component of the crisis response system. So that's just one example of one of those areas. I could go into each one of them and tell you 3 or 4 highlights, but.
Well, let's go to crisis response since you brought that up. Now, you mentioned to me in a previous discussion that the crisis response team in Rockford is like a role model for other areas of the state.
Absolutely.
Talk about that a little bit.
Yeah, I've had the privilege of sitting on a few committees statewide. So one is through our network of other mental health boards. So we participate in a network with them and certainly talk a lot about crisis response. Another thing that took place kind of in those early pandemic years, 2020, 2021, was the passage of state legislation that is kind of unique to Illinois, that is redefining the role of law enforcement as it relates to mental health crisis response. And so that's still being kind of discussed and worked out. How is that going to look when it's fully in effect? So all the mental health boards across the state were really interested in crisis response because of that, and then also 988 coming down from the federal government as this new number that they were going to promote, and people should be calling this number, and in some cases even promoting you should be calling 988 rather than 911 if it's mental health. Now, if it's a mental health emergency, if there's risk of harm, it should be 911. But if it's maybe not a direct risk or emergency, but there's a need, you can call 988. So all this was happening, changing ecosystem of services. And I'm sitting on a couple of these state committees, the mental health boards, and then another one that advises Department of Human Services for our region on what this new ecosystem of services needs to look like. And what we're really finding is that we have, because of the sales tax here in Winnebago County, we have the most ideal set of resources for crisis response because we have multiple options and multiple dispatch types that can go out to a crisis response to really be specific for what the need is. So if you have a crisis response, a mental health crisis, and there is an immediate risk of harm on the scene, that does need a law enforcement response, but does it maybe need a co-responder? We in Winnebago County could have a co-responder team that goes out where it's law enforcement partnered with a mental health professional. Other communities don't have that, so they might have law enforcement go out that hasn't been trained in mental health, that doesn't have a mental health provider with them, and it might just increase the chance of a misassessment.
Right. Yeah, a lot of good work is being done in the community. The crisis response team is one example of something that's being done at a higher level here than other communities. Another program that I always found interesting that is only done here, or at least only done here at the level it's being done, is the Equine Psychotherapy Center at Lockwood Park with the Rockford Park District.
Yeah.
Talk about that program a little bit.
That's a great program. Well, thanks for bringing that up because we probably don't talk enough about that program. And I think the community has really shown up to show their support for that program. I mean, I was really surprised when we went to their ribbon, their groundbreaking ceremony, how many community stakeholders and members showed up in support of that. They really love that program. That program is looking at really what is an evidence-based clinical model. You don't think of it that way because it's not going to an office and sitting in a counseling chair. So you might not think that it has the same research basis, but it really does. And so the equine model is partnering, whether it's trauma or other mental health issues, partnering that person who's experiencing that with a trained person to kind of help them work with a horse. And what the research is showing is that connection between the person who's maybe having issues with emotion regulation or trauma, and then in partnering with the horse, whether it's riding, whether it's grooming, all of those things helps to regulate, really creates this emotion regulation function. And so the horses are kind of special in that way, that they are very attuned to emotion, it seems, and expression, and it can help mirror that back to an individual. So I won't try to articulate all the science of it because I think there's others who are more expert in that, but Rockford Park District, said, hey, we've got this great space out here at Lockwood. We think we can do more with it. They're seeing the need because all of the, kids right now are struggling, especially during the pandemic and even coming out of it with mental health issues. And they said, what can we do with the facilities we have to provide more for these kids?
Yeah, I've had the privilege to tour the facility, and it really is wonderful. And I would like to do a future episode of this program out there as a kind of a walk and talk, so that listeners can see for them and hear for themselves what's going on at that program. When we talk about mental health services, one of you mentioned to me a crisis peer. A certified peer recovery specialist, which is peer-to-peer help, which is also I don't know if it's unique to us but it was an interesting program when you explained it to me. But talk about that a little bit.
Yeah, so it's not unique to us, and it's not even unique to this time. I mean, peer support has always, when you look at the community mental health model, peer support's always been part of that. There just haven't always been a lot of resources for the peers necessarily in getting even a basic level of certification to, okay, I've experienced mental health, so I can talk to you about it and I can relate to you about it, but am I equipped to handle a crisis right now? Mm-hmm. Do I know what to do if that happens, right? Is that safe for everyone? So what some of these new certification programs have done is provide a basic level of training at basically a college level of training, a certain number of courses that allow for that peer who wants to now be part of the helper system to say, I'm equipped to handle this in a safe way. I know what to do if there's a crisis. I know how to refer out. I know how to do a basic level assessment. And so the state of Illinois is really pushing this as a workforce development program as well, because there's such a workforce shortage, and there is not an easy way to get out of it. You can't master degree your way out of it because those degrees take 5 or 6 years sometimes, right? So that doesn't meet the immediate need, whereas peer recovery certifications, where maybe it only takes a year to get through all of your coursework, do an paid internship, and then get into the field and start helping, that's a shorter time to get there. And then it really taps into the personal experiences of people who have been through recovery to say, you can now have your purpose fulfilled by being part of this helping profession that maybe was critical in you getting recovery.
Yeah, you mentioned workforce development, which kind of morphs into another topic. There aren't enough doctors, not enough psychologists, psychiatrists out there. However, there is a program that's being funded through the mental health sales tax that it looks to address that, and that's through the University of Illinois College of Medicine. Talk about that program a little bit.
Really excited about that program because it's not just one entity. It's being spearheaded by the College of Medicine, but it really is a partnership between a number of college and universities locally, Rock Valley College, Rockford University, College of Medicine, and local school districts to, make that pipeline from high school to master's degree streamlined. And then also to create the off ramps for those that don't want to go all the way to the master's degree, but maybe they can still be in the field with an associate's credentialing, or they can be in the field with a bachelor's degree level credentialing. So it's going to be focused specifically on the social work tract. It's going to involve the development of a bachelor's in social work program locally. And what's cool about that is if you get a bachelor's degree in social work, it shaves a year off your master's degree. I went and got a master's degree in social work with a bachelor's degree in sociology. I had to do 60 credits. I had to do 2 internships. It took me a long time to get through it. If you have a bachelor's degree in social work, you only have to do 45 credits. And in some cases, you can get that done in a year and a half. So it really becomes one of those kind of 4+1, 4+1.5 type things. And then if you sync it up really good with your career pathways in the high school, you might be able to shave some time off there as well if you're getting dual credit for some of your high school classes.
Is there a stipulation that the graduates of that program have to stay in Rockford for so many years?
Yeah, the funding that we're giving is really focused on the curriculum and programming development so that even exists, so that local entities, how people pay for that and what the requirements of that funding source are for them to stay in the community has yet to be determined.
Okay. So another program that I wanted to touch on a little bit was through Stepping Stones. There's a supportive housing. They've, just started a group home and are looking to build 11 to 12 more.
Yeah.
Talk about that a little bit. What is a group home, and how does that help someone who's having mental health issues?
Yeah, so critical, and this is really tied into the history when you talk about the removal of hospitals from communities as part of this deinstitutionalization movement. A lot of times we think our mental health issues in our community are because we lost Singer. And part of that's true, but what was supposed to replace that, as you mentioned, was supported housing.
Right.
And the promise was never fulfilled. So we see the vacancy of one resource without the new resource, and we say, well, because that old resource was removed, that's the issue. I believe the issue is that we didn't get the new resource, which was the supported housing. And so I think now that we have this local funding that was developed as one of our priority areas, and Stepping Stones has been in that business for a long time, they know how to do it, and they do it really well. And as you mentioned, they have already completed 1 new group home, which created, I believe, 7 or 8 new beds, rooms, basically. And they're in development of a brand new one, which is going to be a new build that creates 11 or 12 new spaces. What that model does is it provides a higher level of support where you can have staff, mental health clinical staff on site. So that if you've got somebody that has a higher need, they're in and out of the hospital over and over again. And that's what was happening at Singer, frankly, anyways. People in and out like revolving door, because you go back into, you don't have a supported environment to go back to. Right. So then issues flare up again. You end up in crisis again, right back to the hospital. This tries to remove that revolving door thing where it's like you have the supports where you're living on site so that when issues flare up, you get the resource immediately. It's not waiting for it to become a huge crisis where you got to go back to the hospital.
Yeah. We know that intervention works, that people who look for help and get help, their success rate is pretty high.
Yes.
Unfortunately, people aren't always aware of how to access services.
Yeah.
So is there a program that to inform people, educate people on how they can take advantage of these wonderful services that the community offers?
So twofold on that. And so the 2 priority areas I didn't mention were client identification and outreach and the family and community education, right? So on the client identification and outreach, it's really trying to tap into where are the places that people are when their mental health issues start to show up, okay? Sometimes that's 911. Sometimes people are calling 911 even before it's a crisis because mental health issues are flaring up in it. And so there might be even calls that don't sound like it's mental health that's not being expressed, but the things that are being expressed are maybe delusional thinking, right, or something like that, and that's showing up through this reaching out. It's just not saying, "Hey, I need help." So being able to provide mental health resources into our already existing identification systems helps make those connections. So that's one example of that. I think another example is how we've started to have our mental health providers partner with other agencies who we don't traditionally think of as mental health providers, but they're working with people, in a lot of cases, kids. I'm going to give a good example of that as Boys and Girls Club, YMCA. Both of those agencies have been funded to have programs where they're not only helping identify issues and working with kids earlier on like emotion regulation and things like that, but then also have partnerships with mental health clinicians, clinical providers that they contract with who can provide services on site. Because you have to go where people are. You can't just wait for them to come to the resource, because usually if they're doing that, they're waiting until it gets really severe, right? And your chances of crisis are much higher. The other part is making sure family members, friends are aware. What are the warning signs? What are the things that you should be looking for if you're seeing an issue, or even in yourself? How do I know that this thought is intrusive and I should maybe do something about it before it gets worse? So we've got great partners out there. Tommy Coral Memorial Foundation goes out and does mental health first aid trainings around the community, which is exactly what I just talked about, educating community members. What are the early warning signs? How do you identify it? What do you do when you know the warning sign is there? What do you do if you see it in a family member? What do you do if you see it in a coworker? Xavier Whitford's done an awesome job leading those trainings across our community. NAMI Northern Illinois now has a navigator program. Again, that's based in peer support navigation. So maybe I don't want to go to one of these providers and trust that their case manager is going to help me navigate the system, because aren't they really just trying to sell their services? I don't know that that's true, but maybe you perceive that. NAMI Northern Illinois is this neutral organization or community that can help you navigate the array of services within the community from their navigators, and their navigators happen to be peers who can say, yeah, I've experienced this too. This was my experience in this community of trying to navigate the system. Let me help you.
Now, at the beginning, you mentioned that the money from the sales tax has been used to fill gaps within the mental health system. Are there still gaps? What are they? What would your wish list be if you wanted to find partners to create programs to even further the ability for someone to recover or deal with their mental health issues?
Yeah, that's a great question. So we actually did identify, it was probably into our second or third year of funding, we kind of did a little bit of a self-evaluation on that and identified what are kind of some of those remaining gaps. And a few of those we've gotten proposals for. The programs just haven't started yet. So just approved this year was a program through Marshmallow Hope Foundation, and that's going to be focused on developing an intensive outpatient for youth that's really going to be focused on suicide prevention in youth population. So really excited about that as kind of coming on board to fill a gap. Fully transparent, one of the gaps we still haven't gotten the right proposal for, maybe the mental health board at some point will need to be more proactive to figure out how to create this program, is for disordered eating. There's really not a program in town that provides the comprehensive services that are needed. It can be difficult because you really need to have that rooted in a medical system where you have the medical resources, because when disordered eating gets to the point where you need a partial hospitalization or full hospitalization, you have to have a lot of good medical. You need a nutritional specialties. You need a lot of different specialty types, and so you really have to have something that's multidisciplinary. And that would be one that I'd say when I look at the community, I say we still don't have that.
Okay. Well, the mental health board has only been in existence for 4 years now. So it, relatively speaking, this is, very, very new to all of us. And you had mentioned right now your system is based on grant funding. Yeah. And you mentioned being more proactive and actually perhaps creating a program. Yeah. So So how would that work? Are you trying to partner? They're good
Yeah.
at this kind of thing. How do we encourage them
Yeah.
to be even better and do something new?
Yeah, it's a great question. So, not to go into the weeds too much, but this is part of the education of how you manage a public resource, which is public money. Everything has to be kind of open that anyone can respond to it, right? So it's fair. You have to have a process that, hey, we're putting out a funding opportunity. We're going to let everybody apply to it, and then we're going to have a procedure for scoring that, ranking it, evaluating it, and making decisions. You can get more and more specific with that, but the more specific you get, the more time you're putting into one specific thing. Right? Our funding opportunities are, hey, we've got 6 priorities. Here's our strategic plan. We can get 60 requests that fill a variety of gaps, make decisions, and maybe it covers 90% of what we want to cover. How do we start to get into maybe that 5 or 2% that still hasn't been hit? You'd have to basically develop a targeted request and say, we want to see this exact type of program developed, and we're going to receive proposals for that. You can't do that for 60 things, right? So you got to start with the broad proposals and then work your way into the more narrow things as you identify what are the gaps that still remain. So right now, we just completed the first multi-year funding cycle where the board has now awarded, made 41 awards to cover the next 3 years of services for core programs. The board identified that there was about $10 million in surplus funding from the first 3 years that they're going to allocate into one-time awards called accelerator awards that are meant to, what can you do with one-time funding that's going to improve system capacity in perpetuity? The social work program you mentioned is an accelerator award. It may need some long-term support, but for right now, what they're trying to do is just build the program. And then that program always exists, even if there's not additional funding for it in the future. People can come and they can use they can pay tuition to get the education, right? If there's a gap that doesn't get met after all of that, then the board has discussed at some point that they may need to put out a very specific request and say, we need this. Currently, we actually have one that falls into more of our systems coordination function for a HIPAA-compliant rideshare service that will partner with our clinical services to make sure there's door-to-door transportation for mental health. That's a request for qualifications that was developed just for that one thing and put out. Anyone can respond to it. So,
very good. Now, you're the mental health board, in my view, is pretty transparent, pretty open. Impact report, and you can see this. Whoops. This is available. It's online as well, right?
Yeah, that's online. That is our most community-facing document, I'll say. It's really developed for community members to understand what are the impacts that are happening. So we have those online. We also have print copies of those, and I'm happy to come out to various community events and have a table and hand those out. We just had one last Thursday in which NAMI Northern Illinois hosted a national speaker, Brandon Novak, to talk about his recovery from addiction journey. We had over 40 organizations come there with resource booths to say, here's what we're doing. And we brought a box of community impact reports and just gave them out to the community. Like, know what's going on with your sales tax that you voted for. Know what's being spent on.
Yeah, and there like as we've talked about, there are a lot of great programs that are being funded through this. A lot of great work being done. Now, what haven't we covered here in this last half hour or so? There's a lot of innovative programs going on, a lot of programs that are just building on previous programs that have worked. What's missing? What haven't we talked about?
Sure, that's a great question. Well, one thing I'll just say is, again, is are participating in this state network of mental health boards. That in and of itself is its own thing, right? That's a statewide thing by state statute. And so that's new in our community. It's not new in every other community. There are best practices that we look at. There are models that we look at of how are other people doing it. So we really try to root our operation in the best practices that have been developed from the learning from other mental health boards, some of them who have been doing it for 3 or 4 decades. One thing is that this little a saying in that network is if you've seen one 708 board, and 708 was like the original bill number for mental health boards, so they call them 708s. If you've seen one 708, you've seen one 708, which means while there might be some best practices and some common things we all do, we are all unique to our community. And from the way that they're administrated, from the way they're set up, it's all unique. Here in our community, our mental health board has partnered with the Region 1 Planning Council to say, you have a lot of the capacities already built in your operation to the things that we need, like strategic planning, like program evaluation, like funding distribution. So that partnership, I think, has worked really well, and it's gotten us there faster. That's why we're now already into our 4th year of funding. We've already completed our second 3-year strategic plan. We were able to go fast because those competencies already existed. And I think the other benefit of that, which has been shown, is that it has kept the administrative cost so lean. When we benchmark against other mental health boards across the state, the average is about 10 to 15%. And that's actually very fair compared to national benchmarks of government funding. We operate at less than 5% administrative cost here in Winnebago County. So I just would like people to know we're running a pretty efficient operation here. So I know I talk about all the great things we're doing. It's not at a high administrative cost. It's actually at a really lean administrative cost.
Which means more money goes to the people who need it.
Exactly. 95% of the funds, more than 95% of the funds are going out to direct service organizations who are seeing people with mental health and substance use issues.
I think it's charity.com says that any agency that spends less than 25% on its administrative costs is doing well. So you guys are like top of the food chain here. You're doing very, very well.
Thank you. Yeah.
So, hey, thank you very much, Jason, and thank you for those of you who have tuned in or listening or however you're getting this information. I plan to do some follow-up episodes on some of these more specific programs, the supportive housing, the crisis management, the crisis peer recovery. Those are episodes I hope to do in the future. Thank you for watching and listening. I'm Wally Haas, and thank you again to Jason Holcomb for participating in today's episode.